I was there. We were actually pretty good. That's what I imagine it's pretty
Good morning, everybody.
Good morning.
My name is Ginger Spitzer. I'm the Executive Director for the Foundation for Sarcoidosis Research. And some of the other ladies you see around are my staff. And we are just so thrilled to see all the patients here today. Every time we have a patient conference, we see so many faces. It's just a testament to kind of the survivor mentality of sarcoidosis patients, trying to learn and trying to handle the battle of the disease. So welcome all. I hope that the conference is going to be, I know it will be educational to you, and hopefully you'll be able to get something out of it that will improve your battle. So the agenda for the conference is in your folder. We are going to, the doctors will be up here at the panel, and we will have rotating doctors. We also have a Q&A session, and that comes a little later in the program, where you're free to answer or ask questions directly to the doctors. The goal of the conference is really to give you as much information as we can about the disease of sarcoidosis in many different areas. There's a, it's obvious to us and to others that the more information people have about their own health and the issues that they're facing, the more empowered they become to handle those things. And that's really our goal here, is to help you be empowered and to help you handle what we know the difficult time that you're facing as you battle sarcoidosis. A little bit about the foundation. The Foundation for Sarcoidosis Research is a nonprofit organization. We're based in Chicago, but we go all over the nation and really the globe, reaching out to sarcoidosis patients, as well as we also support research in the form of funding and in the form of collaborations and initiatives that will help research be accelerated till it reaches the patient. A lot of times research is kind of this cloud in the sky where people are doing research, but what does that mean to me right now? I can't breathe. And that's our goal, is to make, kind of fill the gap so that that research can travel more quickly to be something that's meaningful to the patient. So again, thank you for being here. I'm going to introduce our, oops, one second. I think I have to move the slide. We're going to introduce our first speaker, who is, one second, Camilla. All right, somebody read their agenda to me. Dr. Wonder Drake, I am so sorry. And Dr. Drake is from Vanderbilt. She's very involved with the foundation, and welcome.
So as Ginger mentioned, I'm Wonder Drake, and I'm just she wanted me to discuss what are the next steps in sarcoidosis research. So you can't hear me. Is this better?
No.
Okay, then my kids say I can yell just fine. Okay. How's this? Is that better? No? Sitting right on it. The light's on. Oh, they can't hear me. Is this better? Good.
Yeah.
Okay, awesome.
So we stay with it.
Yeah, I'll stay right on it. Okay. And if not, just raise your hand. That'll be my sign that you go louder. So, What I'm going to do is just first present just some data that we know, pretty much describing what we understand about sarcoidosis, how many people are getting it, how is it affecting their lives, how many people are actually dying from it. And then I really believe that it helps you most if we kind of discuss what's good that's happening with sarcoid. When you look on the internet, you see a lot of, you don't hear the people that are working full time and taking care of their families with sarcoidosis. You hear the people who are not doing well. And it gives you a biased representation of the disease. So I'm hoping that there's a study that's come out which relates what you can do as a patient to help feel better with sarcoid. And then I'll discuss the role of genetics in sarcoidosis, as well as some results showing that the strength of your immune response is important. And then I'll present some new areas of investigation. So the number of people developing sarcoidosis around the world is definitely increasing. So this is a graph from 2011, which shows that from the circles represent women, the squares represent men, the y-axis is the number of deaths over years, and then the actual year is listed. And what we see is that the incidence for sarcoidosis has increased by about 50% for women and about 30% for men. And when you look, this is in the United States, but when you look in England, they're seeing the same thing, that there are more people being diagnosed with sarcoidosis. And they're also the people that develop sarcoidosis, they typically die from the sarcoidosis as opposed to, for example, complication of treatment or a car accident or some violent episode. They're actually dying from sarcoidosis. What they also demonstrated that if you look by race, the age-adjusted mortality is about 12 times the rate among the African-American age-adjusted mortality is about 12 times 12 times the amount for Caucasians. However, if you look longitudinally, it's actually static for African Americans, but it's starting to climb for Caucasians. So we learned a couple of things. One, the incidence of sarcoidosis is increasing. It's increasing most in women, but it's also increasing in men. And then when you look at by race, the rise is happening fastest in Caucasians, although African Americans still have over 10 times their rate. This is a study that just came out like maybe a few weeks ago, where they looked at what can we do to empower patients who are suffering from fatigue with sarcoidosis. And so this actually happened in Scandinavia. They took 200 people who had clinical evidence of fatigue, and they asked what would happen if we put them in a supervised physical training program over 3 months. How would it affect their fatigue? How would it affect their breathing? How would it affect how far they could walk? Doing what's called a 6-minute walk test. So this is just a demographics of the patients. So there were 54 in the group that did not exercise over 3 months and 57 in the group that did. A little less than half were females, and they were about 49 years of age. These patients had sarcoidosis for quite a long time, at a minimum of 5 years, some much more than 5 years, and that almost all of them were overweight. So they weighed more than they should. At least 2/3 of them were on treatment. And then when you looked at different lung parameters, they had some evidence of impairment, mainly in the DLCO. And then when you looked at chest radiographic stage, so if you look at how bad the sarcoid is based on your chest x-ray, the majority of the patients were stage 1, stage 2. And then they looked at inflammatory markers and they looked at the fatigue score. The good thing about this is that there wasn't any difference in these basic parameters between the group. This is the graphic depiction of what they saw. So what they did is they actually took the patients to a rehab center, and every rehab program was individualized. So they didn't say everybody has to run 5 miles every day. They looked at what you're capable of doing and just asked that you continue to do what you're capable of doing daily. And so group 1 is represented by the dots, and this is the group that participated in the daily physical rehab, and then group 2 is the group that did not exercise. And as you can see, there was a significant decrease in the perception of fatigue just by participating in this exercise program. So by exercising, patients actually felt less fatigue. And then they looked at how far they could walk. Group 1 is the one that was participating in the supervised physical training program. And you can see each line represents a patient. And there was, generally speaking, a significant increase in the amount of distance that they were able to walk compared to the group that did not exercise every day, where it was mainly static. There were a few people you can see that had a slight increase, but most people were unchanged. And so definitely on a program that reflects what you're capable of doing, there was an increase in how far you were able to walk. And then this is just the actual hard numbers. So at baseline, so the 6-minute walk distance is basically how many meters you can walk in 6 minutes on level ground without, your leg falling off or you need extra oxygen or something like that. And so at baseline, they could walk about 513 meters, but after 3 months of exercising at their own individual capacity, the group as a whole increased almost 70 meters, which is 210 feet. Whereas the group that didn't exercise had no change at all. And so this was a significant difference. So it showed that they were on average doing about 74% of what you would predict based on their age. But at this at follow-up, they were about 84%. So almost a tenfold increase in the percentage of what they were capable of doing. And so that study just kind of illustrates that just exercising a supervised training program, which many hospitals do with patients with interstitial lung disease, will actually aid decreased perception of fatigue and also your actual physical capability, so how far you're able to walk. And this difference was seen in 3 months. Now, this is a picture of our current understanding of sarcoidosis. So we don't know what causes sarcoidosis, but the things we do know is that you have a certain type of infection-fighting cell that's called a monocyte. It comes from your peripheral blood into the alveoli, which is the air sac in your lung, and it actually matures right there. And when it matures, it actually will eat up pieces of bacteria or proteins or whatever. It's going to chew it up and actually present little pieces we call epitopes to other infection-fighting cells that we call T cells. So when you have your bronchoscopy, you see these antigen-presenting cells, and you also see these T cells, and the CD4 positive T cells. When these cells meet, we as scientists call it the tri-molecular complex. Doesn't that sound cool? I think it'd be a movie, the tri-molecular complex. And it's the antigen-presenting cell, whatever's driving it, and then the T cell. When they meet, there's a lot of signaling going on inside the cell and between other cells. And what they're really trying to do is figure out how can they get rid of whatever's driving sarcoidosis. If they can't get rid of it, they form something that's called a granuloma. And the granuloma is basically like an immunologic jail. So it's your body's way of saying, I saw something, I couldn't get rid of it, but I'm holding it in prison so that it doesn't hurt you. Now, people form granulomas all the time. Like, I'm sure I have granulomas. I live in Tennessee. There's a lot of histoplasmosis in the dust. And so I'm sure if, when I die, and they do an autopsy on me, they're going to find little pieces of granuloma. So granulomas by yourself doesn't mean that you have sarcoidosis. If you live in an area like I do, the Southeast, where there's a lot of fungi, most of the people on an autopsy in our region have small granulomas. With sarcoid, you have granulomas, and so with my granulomas, they're due to fungi that I've inhaled walking into the hospital every morning for 30 years. But for sarcoid, we're not sure what's driving it, but we know this is telling us that whatever it is, the body couldn't get rid of it, but is keeping it in prison. Does that make sense? Trying to contain it so it doesn't spread to other parts of the body. Sorry. So let me just show you. So the little epitope that the T cell sees is actually presented from some proteins that we call HLA. And these are genes that you get from your mom and dad. You actually use it for paternity testing. Just kidding. And so there's an allele that's in Scandinavian HLA gene called DRB103. When a patient presents with what they think is sarcoidosis, the first thing they do is actually draw their blood and see, do they have this allele or not? If they have this allele, they know that 99% of those patients will resolve their disease in 2 years with no intervention. Isn't that amazing? 99% of them. So this tells us how genetics can help us manage patients. Now, if they don't have the allele, instead of 99% resolving their disease, only about 50, a little over half, will spontaneously resolve their disease in a 2-year period. This allele, this HLA gene, is actually of Scandinavian descent. It's most common in Scandinavia, where a lot of other granulomatous diseases like tuberculosis originated from. The interesting thing, so let me just show you. Let's look at this group that's more representative of the United States, where this allele is kind of rare. So if you remember, it was about 50-50. They looked to see if patients were treated with immune suppressants. If they were treated with immune suppressants, instead of about 50% not resolving their disease, it was higher, like 80%. And then remember, it was about a little over half of people would spontaneously resolve their disease. If they weren't treated, it was more like 60%. So this suggested that at least in the Scandinavians, we don't know that this is true in the United States, but at least in Scandinavia, not receiving immune suppressants can be beneficial. Now, more studies need to be done because this is one report looking at their patients, but it's certainly something to keep our eye on and to pay attention to. One of the things my lab does is my training is in infectious diseases, and we know in granulomatous diseases of known etiology, so histoplasmosis, tuberculosis, the stronger your immune system is, the better. So when we look at people that have active tuberculosis, coughing all over people, hold in their lungs, their immune system doesn't work as well as people who have just a positive PPD with big lymph nodes on their chest x-ray. Does that make sense a little bit? So in animal models, they've shown that you can actually give the mouse or monkey tuberculosis. And if the monkey has a really strong immune response, they'll just have the equivalent of a positive PPD. But if their immune response isn't really strong, they'll get rip-roaring TB. Does that make sense a little bit? And so the stronger your immune response, at least for tuberculosis, the more likely you are to contain it. So what we asked is, we looked at people who had active sarcoid in the lung. So their breathing was worse, or their x-ray looked worse, and compared to people who were resolving their disease. So their x-ray was clearly getting better, their breathing was clearly getting better, and we compared them to healthy people. And what you can see is that, so these are proteins that your body, those T cells that I showed you, these are proteins that they express in order to fight off whatever's driving sarcoid, okay? And so what we can see is that one called IL-2, it's really high, much higher in people who resolve their disease compared to people that have active disease. And so if you compare a healthy control and someone with active disease, it's a big difference. But there's not a big difference if you compare it to people, healthy controls, to people who've resolved their disease. So the immune system in people with sarcoidosis who are getting rid of their disease looks more like a healthy person's immune system compared to somebody whose sarcoid is rip-roaring. Does that make sense a little bit? And it's okay if it doesn't make sense. I can try to explain it a different way because I realize this is science. And so the other thing is interferon gamma. So we saw the same thing, and it's another protein that enables your infection-fighting cells to get rid of things that shouldn't be there. And so with people with active disease, their interferon gamma levels are low. And I should explain to you. So in patients with sarcoidosis, the reason they give you immune suppressants is Ron Crystal did some really elegant work in the 80s, and he showed that when you look at the infection-fighting cells from the lungs of patients with sarcoidosis, they're secreting a lot of interleukin-2 and interferon gamma. And he showed that when you give them prednisone, it shuts it off. Now, what my work shows is that, sure, it's secreting it, but is it secreting the most that it can? What's the best it can do? So it's like, when you have a little kid and they're impressed that they can beat you out to the driveway, and you like the driveway is the standard for trying to run a mile. Does that make sense a little bit? So when you look at patients with sarcoidosis, definitely their cells are secreting more interleukin-2 and interferon gamma than a healthy person's. But the amount that they're secreting is not nearly what they're capable of secreting. And if we want them to get rid of whatever's driving sarcoid, we want them to do the best that they can. Does that make sense a little bit? Now, I don't know if you guys have been studying the cancer studies, but it's really exciting in cancer right now, particularly skin cancers, melanoma, because these really elegant studies are coming out to show that the strength of your immune system also helps you fight cancers. So, in things like melanoma, it's been shown in lung cancer and renal cell carcinoma. So remember I showed you, you have a T cell, you have these genes that I told you, the proteins that present antigen MAC class 2. And a little epitope here. Well, what your immune system does, so you see bacteria all the time. Like when people breathe on you, when they're talking to you and breathe on you, you're inhaling bacteria. When you take a shower, you get a nice dose of bacteria. When you drink from a water fountain, you're exposed to bacteria all the time. And your body, in order to keep you from, blowing yourself up whenever you get a nice little knocking of bacteria, it has a protein on it called PD-1 and PD-L1. And this basically tells the immune system, while you're taking a shower and you're getting all this bacteria that's in the pipe that's bringing the water in, it's saying, yeah, that's a lot of bacteria, but they're just taking a shower, so don't go crazy, just get rid of it, and your immune system does. So it basically lets you keep balance. It's a way to help you keep immune balance. Well, the problem is, so the levels will go high, and then if you follow people over time, you just keep drawing their blood, they go back down to normal, like in hours, definitely in a day, So it's up, down, based on the number. When you have a cold, it's real high. You get over your cold, it goes right back down to normal. Well, in sarcoidosis, people with bad disease, their levels are high. They don't go back down, And so we think that whatever is driving sarcoid, this is its way of keeping the immune system from getting rid of it. Because remember, this protein, PD-1, it's called Programmed Death-1. This protein actually keeps your immune system from being too active. And what cancer does, and what certain infections do, is they say, PD-1, stay up, because as long as you're up, I can keep spreading. But if you go down, your immune system's going to get rid of me. Does that make sense a little bit? So in cancer, they actually have antibody against this drug, against this protein PD-1, and they've shown that their immune system gets better and is able to get rid of the cancer. We looked at PD-1 on T cells of patients with sarcoidosis and asked, how does it look? And so we looked at healthy people, we looked at people who clearly had evidence of disease progression, we looked at people who were pretty early in their sarcoid diagnosis, and we looked at people who were clearly getting over their sarcoidosis. And so healthy people have minimal amounts of PD-1. So it's definitely expressed, but it's minimal, like 2%, 3%. Whereas people that were resolving their disease, it was very low also. People with active disease had really high PD-1, and those who were having disease progression, so their x-ray was looking worse, their breathing tests are looking worse, they're requiring more support, their PD-1 levels were the highest. And so it suggested to us that maybe helping their immune system get stronger by blocking PD-1 is a good thing to do. The other thing that we're doing is we're looking at genes because, a lot of the genetic studies for sarcoidosis have occurred in Europe, where there's a more pure population. The great thing about America is it's very diverse, but it's kind of difficult to do genetic studies because there's a lot of everybody in us. You've probably seen this if you had your mouth swabbed and you realize, like I have a friend who looks completely African-American. Turns out he's 50% white, looking at his genes, So it just turns out that, there's a lot of admixture in our populations. One of the studies that we're doing is something called GRADS, and it's actually complete now. But it's a study where they enrolled 400 people from 9 centers across the United States, and we just looked at different forms of sarcoid, so cardiac sarcoid, people with advanced stage sarcoid based on their chest x-ray, people with early stage sarcoid based on their chest x-ray, people with sarcoid of the skin, and we just asked these really simple questions. Are we seeing a difference in their genes based on how sarcoidosis appears in that patient? And so they're still collecting the data, but one of the things that we've learned is, they enrolled a total of 367 patients, and they've so far looked at 324. And of those, about 3/4 are Caucasian, and then 1/4 African American. It's about 50-50 as far as gender. We have some Hispanics, and the majority of them are have some college education and are the upper socioeconomic status. So it's helpful. This is helpful, and we're going to learn a lot. But we, as you can see from the people that we've enrolled, we also need people who don't have education and who don't have a lot of money, because this is going to help us figure out how sarcoid affects them also. So it'll help us understand disparities in sarcoid. So this study, they're going to look at the bacteria in the lungs of patients with sarcoidosis, the bacteria in the mouth of patients with sarcoidosis, the bacteria on the skin with patients with sarcoidosis, and a few people gave us stool samples. We look at their stool samples too, and just see, can we see a pattern among the bacteria that helps us understand why some people have sarcoid in their heart, some people have sarcoid in their lungs, some people have sarcoid in their skin. So I want you to be thinking about those studies, because that's definitely a really interesting study, and we're going to do a second one as well. And there are definitely clinical trials going on, so you guys look like a pretty savvy group, so you probably know to scan clinicaltrials.gov to just look for new sarcoid studies. So clinicaltrials.gov is basically a website that has all the clinical trials by disease that are going on in the United States. And they have some in Europe, but most of them are from studies ongoing in the United States. And so if you want to know what studies are going on for sarcoidosis, you just go to www.clinicaltrials.gov. And clinical trials is one word. Clinical trials, that you can Google it, Yahoo it, DuckDuckGo it. Any website will pull it up. And then you just type in a term, and you can type in ocular sarcoidosis, and it will tell you where the study is happening. Are they actively recruiting? If they have results, they'll have results in there. You know, if you want to know about pulmonary sarcoidosis, it'll tell you where the studies are occurring for pulmonary sarcoidosis. So it's a great way. So right now, there are probably 12 studies for sarcoidosis going on right this minute. And so this is a great way for you to learn about alternative treatments. If you're saying, I refuse to take prednisone ever again, you know, these are ways for you to kind of think about alternative ways to participate in research. And really, you guys, your participation is what's helping us more than anything. It's what's driving the field, because we're learning a lot through your participation. One of the trials that we're doing is the CLEAR-2 study, where we're giving antibiotics to patients. This is not the Marshall protocol. We're giving people antibiotics with sarcoidosis and just asking, if we give them antibiotics, does that improve their breathing? And so we've already done the phase 1 study. In the phase 1 study, we saw significant increases in how well patients breathe. In the majority of the patients, we saw significant increases. So now we're doing a phase 2, and so it's Vanderbilt, Cleveland Clinic, and University of Cincinnati. But there are a ton of other studies going on at Ohio State, and there's a ton of studies going on for sarcoidosis if you'd like to participate. And then just some new areas of investigation. So the questions that we're asking now, and we had a vigorous discussion yesterday, you know, should you immune suppress or should you not? And you know, really, you guys have been driving those questions, because you come in and you refuse to take prednisone. And so, you know, one of the things we're learning is it a good thing to immune suppress? There's some studies that say not. There's some studies that say that it is. You know, and if so, how much is enough? You know, what's the best type of immune suppressant to use? Should you start with prednisone? Can you give them methotrexate? What about plaquenil? And so there are other studies looking at strengthening the immune system. And is there a way that we can help, by strengthening the immune system, help patients resolve their sarcoidosis? And so there's studies at UCSF that are looking at a special type of CD4 T cell called Th17. There's some genetic studies happening at National Jewish here in Colorado. And then at Vanderbilt, we're conducting these studies also, just looking to see if we improve the immune system, will that help patients get rid of their sarcoidosis? And then one of the other, sorry, I can't quite remember which way to turn this thing. Is sarcoidosis related to an infection? Are microbial antigens present? Are there proteins related to it? And so that's work that we're doing at Vanderbilt, but there's also similar work happening at Johns Hopkins, as well as the Karolinska. So a lot of us are just trying different ways to figure out what's driving sarcoidosis. Why do some people get better? Why do some people not? What can we do to kind of help patients get better? And then number 4, are there differences in the different types of sarcoidosis due to different genes? And if so, which genes are those? And then that's the GRADS investigation that I just told you about. And then Dr. Montgomery at the Oklahoma Medical Research Center is also doing a similar work, where we're looking at the genes of patients with different forms of sarcoid to see if we can find patterns that will help us understand why they have different areas of involvement in throughout their body. And then there's a really nice study that I think is almost finishing, but still ongoing. So not smoking, do not smoke. But if you give patients like a nicotine patch, will that help their sarcoidosis? And so Dr. Krauser is still doing that investigation, and there's additional studies. I mean, when I went on clinicaltrials.gov, there's like 12 studies right this minute going on for patients with sarcoidosis. Okay, does anybody have any questions? Oh, yes, ma'am.
Will you have a PowerPoint or a PDF file with me and
Yeah, so I have sent it to FSR, and I think they will, let me not speak out of turn.
When you're talking about strengthening the immune system, it made me think about gamma globulin. Has anybody tried using that?
I know they've used it in sarcoid patients that get CI, common variable immunodeficiency, so sarcoid patients that don't have normal antibody levels. I know I have a couple of patients in my study that they get monthly IVIG, but I don't know that most sarcoid patients have a lot of extra antibody, and they're not sure why it's there. So probably they wouldn't give them even more antibody. And then, so is it fair to say that the slides that we sent you, you guys will make available to the patients?
Yes. If you see the green that's going around right now, it means it's being recorded. So we'll be sending that out to everyone.
Okay, thank you so much.
All right, can y'all hear me? Yes? I'll try to yell. So I'm Ennis James. I'm a physician at the Medical University of South Carolina in Charleston. You can see our medical center up here. It's a beautiful surrounding, so please come and visit us. And if myself or Dr. Rich Miller ever has enough money to get a boat, I promise we'll take you out on it. That's probably never going to happen. So I'm going to be talking about treatment options today, and this is a huge topic, sort of as Dr. Drake alluded to, and it's a big challenge to talk about it in 20 minutes. So I'm going to really try to hit the highlights. I feel like it's appropriate to start with a inspirational quote, so to speak. So there are no such things as incurables. There are only things from which man has not found a cure. If you're familiar with the FSR website, that's actually where I stole it from. It was done by a guy named Bernard Baruch, who's a famous philanthropist back in the earlier part of the 20th century. And I didn't realize this, but he actually had something to do with my own trip towards being a sarcoidologist. So he donated money in his dad's name to build the auditorium where I spent my first year of medical school here in USC. Small world. So I think it's impossible to talk about treatment without talking about the pathogenesis. Dr. Drake helped me a lot with that, so I'll just sort of reiterate a lot of what she said. And then specifically doing that with the focus on where do we think the treatment currently helps. And then how do we decide who needs treatment? And this is a very big challenge for us as clinicians. Is, we can't just say everybody that has sarcoidosis automatically gets prednisone. So I'll give you some insight into how we sort of make that decision. And then we'll go over some specific treatment options in pulmonary sarcoidosis, and then a couple of alternatives in other disease organ manifestations. So if we look at the diagram, we can see there's some sort of unknown antigen or trigger. There are some trials going on sort of investigating whether or not it's an infection or it's metal dust or organic dust, but at this point we're not 100% sure what it is. But regardless of what it is, you get an inflammatory response that's abnormal, and that inflammatory response leads to granuloma formation. And if we look in more detail at that granuloma formation, we can see that the antigen really can act in at least 3 different pathways. So one of those, and all these pathways lead to granuloma formation. And so one of those pathways, you get binding of the antigen by certain cells that travel to the lymph nodes in our chest, where they basically say, all right, guys, we got something abnormal. Let's get a bunch of immune-fighting cells. And then those cells are released into the blood vessel, and then they travel back to the lung to sort of aggregate around these granulomas. While that's going on, at a couple of other sites, you're getting release of what we call cytokines. And basically, these are substances that encourage that ongoing inflammation and immune response. And the reason I wanted to introduce this concept was that there are specific cytokines that we're able to block with certain medicines, such as TNF-alpha, which I'm sure some of you are familiar with. And then also other drugs which actually block production of some of these lymphocytes that are recruited in the lymph node, like azathioprine and that sort of thing. And so if we look to the point of when the granuloma is actually formed, you really have two different ways the disease course can go. You can have resolution of the disease. And fortunately, at least in pulmonary sarcoidosis, that's the majority of patients will end up with that disease course. Or you can have fibrosis. And trying to figure out which patients go where is pretty difficult, which can make deciding on treatment options pretty challenging. So with that in mind, so what can we treat? So again, as Dr. Drake alluded to, there are some trials going on about seeing if antibiotics will help, and that may sort of give us some clues that there's an infectious cause to it. But right now, by far and away, the most common treatments we have suppress inflammation. And by suppressing inflammation, we improve symptoms, and the ultimate goal is to prevent fibrosis while we sort of allow the body to figure things out and move towards resolution. A question I get almost every week in clinic is, what do you mean I don't need treatment? I have sarcoidosis. I hear it's bad. Why aren't you putting me on medicine? And I think the reality is that the indications and potential benefits of therapy in this disease aren't always quite clear. And then the potential side effects, as a lot of you can probably attest to, can actually be worse than the disease. And so what we really have to do is decide, based on studies and experience, who we think needs treatment. And so, as we know, a lot of patients will have resolution of disease without any treatment at all. And so this is a very old study done back in the 60s by a man named Dr. Scatting. And what he did, he basically categorized patients based on if you have big lymph nodes or lung involvement. And then, depending on what you had, he determined how likely it was that you were going to have resolution of disease. And as we can see, 75% of patients had lymph nodes when they presented on their chest x-ray. And the vast majority of these patients had resolution. So you can imagine, from a clinician standpoint, even though you have an abnormal x-ray and we have a biopsy that shows you have sarcoidosis, if I think there's a good chance you're going to have a resolution of disease, I don't want to put you on a drug that's going to make you gain weight and get diabetes. And also, as Dr. Drake alluded to, there is evidence that putting people on prednisone may actually decrease the chance that they have resolution. So then that leads us to the question, when should we actually start somebody on treatment? So symptomatic disease, as a general rule, is a good indication to start somebody on treatment. And then without symptoms, you can have organ-threatening disease. So eye involvement, hypercalcemia, high calcium levels in the blood, that can lead to kidney damage. Heart and central nervous systems are two organs that get involved that scare us as clinicians. And then advanced lung disease, which is still the most common cause of death in sarcoidosis patients. And sort of in the background of this, we look for presence of certain factors in patients that we know are associated with a worse prognosis. So with those listed right here, African American race, older age, extensive lung disease is kind of a no-brainer. Lupus pernio, which is a particular kind of skin involvement, and then nephrocalcinosis, which is basically calcium deposition in the kidneys, and large liver, cardiac, and bone involvement have all been associated with increased likelihood of progression of disease. Keep in mind that these are just things that we consider. You know, not every African American who's 45 is put on prednisone, but that's just something that's sort of in the back of our minds when we're trying to risk stratify somebody onto whether or not they need treatment. And so what we're left with as clinicians and patients is this balancing act, where each patient, you can imagine, has this pathway to walk. And what our job is to balance the symptoms and the risks of the disease with drug side effects and sort of help you as patients get through the disease. And I think it's very important to note that sarcoid is unique in that we don't just have a blanket statement that says, oh, you have sarcoidosis, this is how we're going to do it. So everybody's different, organ involvement is different, and so everybody really has to be considered on an individual basis. And I think that really gets to the importance of having a patient-centered approach where you as patients are educated on the disease, y'all are contributing to the decision-making process by your physician. There are some physicians out there that probably would say, what are you doing? Don't tell them that. But I think in this disease, because of the potential side effects and because the symptoms can be so variable, it's really important to have more of a doctor-patient team model. And I feel like within that model, it's really our job as physicians to be sure that we can answer all these questions when we start you on a drug. Because if we can't, then I would argue that maybe we shouldn't be starting that drug in the first place. So these are all good questions for y'all to consider when you're getting started on treatment. So how does it work? Why are you starting me on it? How long will it take to work? Some medicines can take up to 6 months to have an effect that patients can actually feel. And so that's important for you to know, as opposed to walking out the door and the next day you're wondering why you're not feeling better. And then how long should you expect to be on treatment? Is this going to be 6 months or 5 years? And then how will we monitor side effects? All right, so on to the specifics. Just as each patient should be considered individually in terms of treatment options, each organ should be considered individually in terms of deciding what medications work best. Because the studies have shown certain medicines will work better in cardiac sarcoidosis, but not pulmonary sarcoidosis or skin sarcoidosis. And I feel like the best way to present the at least initial information about some of the medicines was to go through some case presentations specifically dealing with pulmonary sarcoidosis and sort of give you some insight as to what medicines we choose and why. And we'll talk about typical doses, side effects, and then how we monitor for those things. And at the end, I'll very briefly mention, here's some other medicines that we use, because there are a lot of medicines out there that are available that just don't have a lot of data. But I feel like you as patients should at least be aware that they're out there. So on to patient number 1. So she's a 30-year-old female, biopsy-proven sarcoidosis. She has stage 2 disease, so you can, on her x-ray, right around the heart, she has a lot of swollen lymph nodes and some evidence of lung involvement on the outside of the lung zones. She has worsening shortness of breath and cough. And so if we look at this treatment algorithm that was proposed by Dr. Kaufman, we can see she has biopsy-proven disease and she has symptoms. So our next job is to rule out other causes. So she doesn't have TB, she doesn't have infection, and at that point, because she has symptoms, studies have shown that starting patients on prednisone can help with resolution of symptoms and disease. And so the initial dose for pulmonary sarcoidosis is in that 20 to 40 milligram range, with most physicians probably now leaning closer to that 20 milligram dosage. So once your symptoms are controlled, what we try to do is taper that dose by 50% every 6 to 8 weeks, assuming that your symptoms are still under control. And then the treatment goal is really to get down to a dose of 5 to 10 milligrams, and we continue that dose for around a year, and then get you off steroids. I can speak personally that I have a very dysfunctional love-hate relationship with prednisone, because it works for a lot of patients, but the side effects are just crazy. So I don't want patients to be on prednisone for a very long time. And of course, a lot of you can attest to the side effects of prednisone. So weight gain is always a big problem. Blood sugars, it can cause eye problems, it can elevate your blood pressure. Interestingly, it can cause you to be profoundly depressed or manic and not able to sleep at night. And then of course, if you're on these medicines for a long period of time, the risk of bone thinning and osteoporosis is there as well. So if we go back to our patient, she was started on 20 milligrams of prednisone. Fortunately, her symptoms improved on that dose. She was able to be weaned to 5 milligrams by 3 months. She did have a 10-pound weight gain, but her blood pressure was okay and her blood sugars were normal. So we felt like that was an acceptable side effect profile. And so we continued that for a year and then stopped it. And fortunately, at this point, 2 years out, she still has no signs of relapse. And I feel like this is a good example of an ideal treatment outcome for a patient with pulmonary sarcoidosis. To me, this is sort of a best case scenario where you only need one medicine, you have minimal side effects, and you have no signs of relapse off the medicine years down the road. As we'll see, that's not always the case in the next couple of patients. So patient number 2 is a 45-year-old, has biopsy-proven sarcoidosis that's stage 3. So you'll see he doesn't have evidence of lymph nodes around his heart. He does have uveitis though, which is, there's a picture of that here, which is basically inflammation around the eyes. He was started on 20 milligrams of prednisone and his symptoms did improve. However, when we tried to go below that dose, his symptoms immediately came back. He was having a lot of shortness of breath as soon as we dropped it below 20. At the same time, he also gained 30 pounds over 3 months and was starting to have symptoms of sleep apnea, so clearly was not doing well with prednisone. And so at this point, if we go back to our algorithm, we can see he's already tried prednisone. We couldn't taper to less than 10 milligrams. And so now we're left with second-line agents. So methotrexate is by far and away the drug that has the most evidence to support its use as a second-line agent. It's a little unusual in that it's a weekly dosing regimen, so every 7 days. It's most commonly given orally. The most common side effect is nausea and vomiting, though, with oral dosing. So there is an intramuscular or subcutaneous form that a lot of patients can do well on if they have nausea and vomiting. It can cause low white blood cell counts and abnormal liver function tests, so we always do CBCs, which is a complete blood cell count, and LFTs, which is liver function tests, more frequently when we're first starting the drug, and then we can kind of slow down as long as you tolerate it. About 2/3 of patients will respond to the medication. And then the addition of folic acid has been shown to decrease the likelihood of some of these side effects. Azathioprine has a similar treatment response rate to methotrexate. It's an oral daily dosing, similar side effect monitoring, but there is a relative increased risk of infection compared to methotrexate, which is why it's not used as frequently as methotrexate in a lot of patients. And then leflunomide was originally developed as an alternative to methotrexate in rheumatoid arthritis with less side effects. They accomplished that. It does have less side effects. There's some suggestion that it also may not be as beneficial as methotrexate, and there's also one study looking at actually the combination of methotrexate and leflunomide where patients did better on the combination of the drugs. And I think it's important to point out that these medications, the goal of treatment with these is to have them be steroid-sparing agents. So when we start you on these medicines, we're going to have you on it for 6 months, and hopefully by 6 months we'll be able to start decreasing the dose of prednisone that you're on and be avoiding all these side effects. And so none of these medicines are going to make you feel better in a week or 2 weeks. They're going to take a long time to have an effect. And they're all contraindicated in pregnancy, so you always need to be sure that you're using contraception and that aren't currently pregnant at the time we started, obviously. So if we go back to our patient, he was started on methotrexate 10 milligrams. All of his labs were fine. We increased him to 15 milligrams after 6 weeks. He had no signs of drug toxicity. By 6 months, we were able to get his prednisone down to 10 milligrams. And by a year, continuing that 50 milligrams of methotrexate, we're able to get it completely off. And he continues to do well just on the 15 milligrams of methotrexate. So patient number 3 has a little bit even worse disease. So she's 40, has biopsy-proven progressive stage 4 sarcoidosis. So from her chest x-ray, you can see there are actually areas of the lung where there's scarring and missing lung tissue. And she also has skin sarcoidosis. She originally was started on prednisone, didn't really respond. Methotrexate was added, but by 6 months, she had no response to treatment, and actually her liver function tests were worsening, suggesting that she was having toxicity. And so if we go back to our algorithm, we can see at this point, you're at third-line agents, which the most commonly recommended medicine right now are TNF-alpha inhibitors, infliximab and adalimumab. And so part of the reason I wanted you guys to be familiar with the pathogenesis of these drugs is that they block one of those very specific cytokines that promotes the inflammation in the disease. Infliximab has the most evidence to support its use. It is an IV infusion. Usually patients will be started out 0, 2 weeks, and then 6 weeks, and at that point you'll be continued on a maintenance regimen every 6 to 8 weeks. It can cause low white blood cell counts, so you will need to have blood counts monitored. And probably the biggest problem with this medicine is there's a risk of an allergic reaction to the medication itself during the IV infusions. The way they created this medicine was by actually taking a protein from a mouse and then adding something on that blocks TNF alpha, and then they give it to us. And so some patients will have a reaction to that protein specifically. It's a relatively low risk though. Adalimumab, patients tend to like it better because it's a subcutaneous injection and it's not an IV infusion. Unfortunately, it is a little bit less potent than infliximab, and it takes a longer time to have an effect. So whereas infliximab, after a few weeks, will usually be working, sometimes adalimumab will take up to a couple months. And it's very important to point out that you must have no evidence of tuberculosis, because a big risk of these medicines is that you can get reactivation of what's called latent tuberculosis. So you've been exposed to it in the past, but you didn't have symptoms at the time. And if you would give these medicines and suppress your immune system, they can flare up. So if we go back to patient 3, the methotrexate was stopped, obviously, started on infliximab, had improved pulmonary symptoms by 2 months, and his LFTs were also doing better, his liver function tests. Prednisone was then decreased to 10 milligrams, and so right now we're leaving him on 10 milligrams and the infliximab with the plan to continue to wean steroids as tolerated. So other treatment options, a lot of patients will have benefit from a sarcoid-associated cough with high-dose inhaled steroids. There's no evidence that high-dose inhaled steroids will help progression of lung disease itself, but it can help with the cough. Plaquenil or hydroxychloroquine is another medication that has some evidence behind it. It's particularly good for skin sarcoidosis and high calcium levels related to sarcoidosis. It can also take months to have an effect, and you need to get frequent eye exams because it can cause some eye damage as well. Aquilar gel is a medicine that's been around since the 50s. It's receiving a lot more publicity here recently. It's basically stimulates your body to make more prednisone. So instead of giving you prednisone, it makes your body make more steroids. So it has a similar side effect profile. There are some theories that there's some other receptors that it may bind that provide additional advantages over prednisone. It's an IM injection every 24 to 72 hours. Right now, it's generally considered as an alternative third-line agent. And there are some ongoing research trials using it in high calcium levels and things like that. So I wanted to mention cardiac, neurologic, and skin involvement. Skin involvement because it's one of the most common other organ involvement in sarcoidosis. Cardiac and neurologic because those are 2 organ manifestations that we have to treat really aggressively. As you can see, prednisone is the first-line agent for all of these. The difference is really that in cardiac, the dose is a little bit higher based on a Japanese study. In Japanese patients, there's a lot higher incidence of cardiac sarcoid over there. And then neurologic, we're a lot more aggressive with prednisone dosing because we really have to be sure to suppress the inflammation in the brain quickly or the risk of damage is worse over time. Skin involvement, hopefully you can just get by with topical steroids, but if it's a severe manifestation, you'll end up needing some oral prednisone as well. So there's tons of drugs out there. I'm not going to go through all these individually, but I think it's important to point out mycophenolate and cyclophosphamide are 2 options. There's sort of inconclusive data with pulmonary sarcoidosis with these medications. Some people think mycophenolate may work in pulmonary sarcoidosis, some don't. There is better data that they probably work a little bit better in cardiac and neurologic sarcoid. Skin involvement's interesting. You know, they've used everything from other antibiotics, minocycline, tetracycline, to the Clear regimen that Dr. Drake used in one of the original Clear trials treating skin sarcoidosis. And there's some newer agents, apremilast, which is an inhibitor of a specific phosphodiesterase, and then golimumab, which was another TNF alpha inhibitor that was tested for treatment of pulmonary sarcoid, which it didn't work out to be beneficial for that, but there was some evidence that maybe it may help in skin sarcoidosis. So that was a lot of information, but I just wanted to end by another inspirational comment. So that's great that y'all are here. We can do everything in the world from our end, and we'll never get anywhere without you guys. So it's key that y'all are here and involved. So please continue to do that. We appreciate it. And I'll be happy to take questions.
Okay, I'm going to start at the front here and work my way into the back. Please note we do have a Q&A session later, so if it's not pertinent to the slides, please hold your questions.
I was just curious if you have any experience with low-dose naltrexone.
Specifically with fatigue.
Just sarcoid in general.
I know that it's been used, so no, personally I don't have any experience with it. I know that it's been used in Crohn's disease, which is another granulomatous disease that's really a separate process. There are some people that think using naltrexone with fatigue associated with sarcoidosis may be beneficial. And I do know physicians who have tried it on patients with sarcoidosis related fatigue and had some good outcomes, but there hasn't been a trial to my knowledge using it.
Okay, next question.
Have you had any reactions from your patients who took flufonamide or Remicade getting discoid lupus rashes?
I have not personally. I have heard of patients, specifically with infliximab, you can almost get a sarcoidosis-like reaction. So there is some evidence that it can actually precipitate an abnormal immune response. I haven't heard discoid lupus being a specific one of those, but there is possibility. I don't know if one of you have seen that either.
I've seen skin rash with,
Yeah.
with infliximab, not necessarily discoid lupus,
Yeah.
diagnosed discoid lupus, skin rash.
Okay, next question.
Are there any studies for like any natural remedies such as large doses of curcumin as an alternative to methotrexate?
That's a very good question. So curcumin, I don't know about specifically. I know that Marjolein Drent and a group over in Europe used, it's basically the equivalent of vitamin C. I think it's quercetin maybe, where they actually gave it to patients with the thought that it would help suppress some of the immune system, and it was inconclusive results, but it was a very small study, I think maybe 10 to 20 patients. But the reason I think it's a good question is I think it's interesting, the idea of using things like high-dose vitamin C or something else is an interesting possibility, but there just aren't studies out there that I'm aware of. So. All right.
Wonderful, thank you so much. Sorry.
Yeah, you mentioned a drug earlier that pregnant women shouldn't take. Is that one that would cause severe birth defects like that thalidomide did? Or?
Right. So all three of those second-line agents, the methotrexate, azathioprine, and leflunomide, all have what we call teratogenic effects, meaning that they can cause severe damage and severe birth defects if the mother's on them while she's pregnant. All right. Thanks.
Hello, everyone. I'm Richard Rissmeller. I work with NS at the Medical University of South Carolina. I'm mainly a clinician educator, so I'm not a scientist like Dr. Drake. So for me, this is a big honor to be able to speak to this group because this is what I do all day, every day, is take care of sarcoidosis patients. This I took from the internet. It was someone had posted that on social media, that sign there. I'm not sure the grammar's correct, but I think that the spirit of it is correct, that sarcoidosis is a disease that can affect any organ in the body. And I'm going to spend a little bit of time today talking about some of those organs. I'm originally from Philadelphia, so I have a lot of trouble staying behind a podium, but the good news is I'm loud and I talk with my hands. So if I come out here, don't worry, I'll talk loud. So, organs involved in sarcoidosis or sarcoid, as I said on the last slide, it can really be any organ in the body. And I've seen some unusual ones in my practice at MUSC over the last couple of years. Thanks. So some of the more common organs that are involved are the lymph nodes, obviously, the skin, the eyes, the musculoskeletal system. And I'm going to talk a little bit about some of those, and then we'll spend a little time talking about some of the less common ones. So this was the AASOG trial, which was a study that was done in the early 2000s. And basically, this slide, which is difficult to read, I know, basically just summarizes the likelihood of the patients enrolled in that trial to have different organ involvements. And as you can see there, the lungs were by far the most common. And then as we move up, they become less and less common on that list. So because lung disease is the most common, I thought we needed to talk about lung disease just a little bit. I'm not going to talk about the interleukins and the cellular. I think that's been covered excellently by Dr. Drake and Ennis. I'm going to talk a little bit more about the clinical disease. So lung disease is about 90% of all sarcoidosis patients. And I thought it would be interesting to spend a little bit of time to talk about how we assess the degree of pulmonary involvement. Because, when we have to make these treatment decisions, like Ennis pointed out, we have to assess the degree of organ involvement with every organ in patients that we treat for sarcoidosis. So I thought maybe it would be interesting, since lung is the most common, to talk a little bit about how we do that. Some of you may already know what I'm going to talk about, but I thought it'd be a good review anyway. So often what we do is we get pulmonary function testing. We get chest imaging. Most commonly, probably an X-ray or a CAT scan. We're going to talk a little bit about PET scans and MRIs in a little bit. And then either objectively or subjectively, we measure the patient's shortness of breath. We ask them, are you short of breath? What kind of things can you do around the house? Can you do your normal activities? Do you get short of breath walking up a flight of stairs? Whatever way we use to assess shortness of breath. So pulmonary function tests. What are pulmonary function tests? Well, I just wanted to go over a little bit of the basics of what they are, so you have a little bit of understanding. So I'm not going to talk about lung volumes here. I'm going to talk about what we use in daily practice more commonly. Initially, we get lung volumes when we're initially seeing a patient, but more commonly in patients with pulmonary sarcoidosis, what we follow is spirometry and diffusion capacity. Those are the two things that we follow to assess response to therapy. And the FEC is basically the amount of air you blow out. So you do a force maneuver, and I'm sure a lot of you have done these tests. And you do a force maneuver, and basically the machine measures how much air you blow out. Now, normally I don't have any lung disease, at least that I'm aware of. So when I blow out, I should be able to blow out the majority of the air very quickly out of my lungs, because my airways are normal and my lung parenchyma is normal. So how we assess that is by the FEV1. That's the amount of air that we blow out in the first second of that forced expiratory maneuver. Okay? I should be able to blow out almost all of the air in my lung in that first second. What we decide as being abnormal, our abnormal is 70%. Okay, that's the cutoff for that. So our FEC to FEV1 to FEC ratio should be greater than 70%. Diffusion capacity is the second thing that we look at when we're following patients. And diffusion capacity, the simple way, it's a complicated test. Basically, how it works is you inhale a small amount of carbon monoxide, not enough that's poisonous, but a small amount. And then you exhale. And we measure how much of that carbon monoxide has been taken up, how much you exhale minus how much you inhale minus how much you exhale, tells how much was taken up by the hemoglobin. Okay, and that gives us a good indication of how well oxygen is being picked up in the lungs. We're using carbon monoxide as a surrogate for oxygen to see how well the oxygen is being picked up. And we decided normal there should be greater than 80% of predicted. So if you're less than 80% of predicted, your diffusion capacity is abnormal. And when we do this testing, what we're determining is whether the patient has restrictive lung disease, obstructive lung disease, and reduced diffusion capacity. So restrictive lung disease means you don't have enough air in your lungs. There's fibrosis, there's inflammation, and you can't take a big enough breath. There's too little air in your lungs. And that would be indicated by a reduced total lung capacity or reduced FDC. We use FDC as a surrogate for the total lung capacity. Then obstruction, which is also very common in sarcoidosis. Obstruction is something that we think about with asthma or COPD. Right? You can't blow all the air out in a timely fashion, an airways disease. But we often see that in sarcoidosis, where that ratio of the FEV1 to the FVC is reduced. It's not greater than 70, it's less than 70. And then we use the diffusion capacity in a number of ways, but one way we use it is to determine if the patient's more likely to require oxygen. The lower the diffusion capacity, the more likely they are to require oxygen. So this is one of my patients, okay, and I blacked out the identifying data, but this is from our lab at MUSC, and this is a patient I know very well, and I've taken care of her for over 2 years, and she's very sick with her sarcoidosis, often in the hospital. And as you can see there, the FVC is the top number, and that the thing that says pre, that column, that's the actual measured number that she had. So she blew out 1.63 liters of air in her forced expiratory maneuver, and that was only 53% of normal. Her FEV1, I cut it off there a little bit with the circle, but it's 0.99 liters, okay, which is again markedly reduced, 39% predicted, okay. The FEV1 to FVC ratio, remember I said that has to be above 70% to be normal. That's at 61%. So that again is reduced. So this patient who has very severe sarcoidosis has both restrictive lung disease, in other words, her FVC is reduced, and obstructive lung disease. Her ratio is reduced. And her diffusion capacity is very low. And she's on oxygen. She's on about 4 to 6 liters of oxygen continuously. So this is again one of my patients, and this was a CT scan that was obtained in a patient that presented acutely with sarcoidosis. And this doesn't show the lymphadenopathy very well, but what you see here is the chest. Okay, so the top of the screen, it's like the patient's lying this way with their feet up in the air. And you're looking at a cross section of their chest right here. So this is the top. That's the bottom down there. Those are the big breathing tubes, the left and right main bronchi. But it's backwards because you're looking at them this way, so the left's the right, the right's the left, okay? So so you see all those little white spots, okay? The lung should look black, okay? There shouldn't be a lot of uptake in the lung in the CAT scan, right? All those little spots that you see are nodules. And all those nodules most likely represent granuloma formation. So this patient has active inflammation in their lungs, and it's indicated by all those little white nodules that you see. Now this is another one of our patients in clinic, and Ennis is actually seeing this gentleman now. This gentleman has what we call fibrocystic sarcoidosis. So this is when that acute inflammation that we just talked about has progressed to fibrotic change. And he's developed all these large holes in his lung, okay, that most likely are from destruction of the lung due to that chronic inflammation. So these two patients, both of them have pulmonary sarcoidosis, are in different stages, okay, and probably should be treated differently. But we have a lot of difficulty figuring out, one of the things that we're trying to do with conferences like we're having here is to figure out how to put these patients in the right place so we know how to treat them appropriately. Okay, so I'm going to shift gears and talk a little bit about cardiac disease. So traditionally in the literature, what you read in textbooks, we learn in medical school, is up to 20% of sarcoidosis patients in the United States have cardiac involvement. Personally, I think it's higher. And there's some data to suggest that I'm correct, but it's not been proven. The thing that we worry about in patients with cardiac sarcoidosis are the two things that I list there at the top. Arrhythmias. Okay, so arrhythmias are abnormal heartbeats. And there's arrhythmias that are annoying or can cause symptoms, but they're not life-threatening. And then there's life-threatening arrhythmias that can cause patients to have sudden cardiac death. And I have at least 3 patients in my practice that have had sudden cardiac death from undiagnosed sarcoidosis and were subsequently referred to me. So it's not a common thing, but it definitely happens. hopefully no one in the room has experienced that. And then over time, as you have this inflammation, that same inflammation that we saw in the lung, we see it in the heart, and I'm going to show it to you on imaging here in a second, you can develop over time cardiomyopathy, which is basically a fancy term for your heart doesn't work as well as it should. Your ejection fraction is reduced. The amount of blood that the heart can pump is decreased. And that's what we want to avoid. Rarely you can get other cardiac manifestations of sarcoidosis, such as valvular heart disease, mashed lesions in the heart, pericardial disease is disease in the sac around the heart attacks, and then we talked about sudden death. So how do we screen, if we have a patient that we know has sarcoidosis, how do we screen them for cardiac sarcoidosis? Well, we all do EKGs. That's very common and well accepted. So we want to, and the reason we do an EKG is to screen for arrhythmias, because arrhythmias are the thing that we really worry about, because that's going to lead to in the short term, because that's going to lead to sudden cardiac death. So we really need to pick up on arrhythmias. Now, further, echocardiogram has been suggested. An echocardiogram is a good test because it lets us see how the heart's functioning. And echocardiogram is really just an ultrasound of your heart. And it shows us how well the left and right side of the heart is functioning. And if it's abnormal, then that's going to raise our suspicion for cardiac sarcoid. It doesn't diagnose cardiac sarcoid, but it would raise our suspicion if it were abnormal. And usually we don't get that on every patient that we see, at least I don't. I do it quite commonly though, and I do it if I have any suspicion based on their symptoms that they could have cardiac involvement. So I have a very low threshold for getting that test. So pretend we do those two tests, and I still have a high suspicion that the patient has cardiac sarcoidosis. They have sarcoidosis, they either have an arrhythmia on EKG, or they have an abnormal echocardiogram that I can't explain in some other way, and I'm concerned that they have cardiac sarcoidosis. Then what do I do? Well, you would think, well, the way we diagnose sarcoidosis is to see granulomas on biopsy, right? So why wouldn't I biopsy those people? Well, unfortunately, cardiac biopsies are, as you can imagine, fairly high risk. And oftentimes, if you don't get the right spot, you can miss the granuloma in the heart muscle. So you can put the patient through a procedure that's risky, to say the least, and then at the end, you still don't know whether they have cardiac sarcoidosis. So that's probably not the best test. And at our institution, we don't do very many cardiac biopsies for sarcoidosis. I can't say that they're not done, but they're infrequent. So we look for another way to try to determine whether somebody has cardiac sarcoidosis. And the two ways that are common in 2015 are the PET scan and the MRI scan. And this is a PET scan. This is a piece of one of the PET scans. This is not from my patient. I took this from the internet because I didn't have as good an example. But as you can see, that's the heart there. Similar to the chest CT we just looked at, the front of the chest, the back of the chest, the lungs there, the dark areas on each side of the lungs. That's the heart right there in the center. That's part that's lit up with the purple and the yellow. And that's abnormal, okay? So what a PET scan does is it looks for metabolic activity. So people who undergo a PET scan are given a radio tracer that's sort of like a glucose solution, and where the cells are very active, where there's a lot of inflammation, that glucose gets taken up and it can be seen by the PET scan. So this PET scan indicates that that patient's heart has a lot of inflammation in it. MRI scans are another test that we do for sarcoidosis. They have some advantages. When you do an MRI scan, you don't see that nice lighted up heart that we just saw on the last page, but you can see acute inflammation presenting as thickening or signal intensity when contrast is given on the MRI. The other thing that's good about an MRI is it's kind of another way to look at the heart function. The MRI gives us a lot more information about the function of the heart than the PET scan does. So if the heart function's abnormal, we can see it on the MRI. So here's a little bit of data that suggests what I mentioned earlier, that probably cardiac sarcoidosis is a little bit more common than we suspect, and probably we should have a fairly low threshold for doing one of these tests. So look for it if patients have symptoms that make us worried about. Also, there's some autopsy studies that show that patients with sarcoidosis have involvement in their heart at a high prevalence. So this is what I've already discussed while we're talking about this. So all of my patients get an EKG. The majority get an echocardiogram if I have any suspicion that they could have cardiac involvement. And then I have a very low threshold for the PET scan. I like the PET scan personally to evaluate for cardiac sarcoidosis, because not only does it give you the metabolic activity in the heart, it also gives you the metabolic activity in the rest of the chest. So it kind of gives me that extra little bit of information. But there's certainly no study that shows that PET scans are superior to MRI scans. And then we can also do cardiac event monitors to look for arrhythmia. So treatment of cardiac sarcoidosis, Ennis already mentioned this, immune suppression, which we use at relatively high doses. And then the other thing that we do to treat cardiac sarcoidosis is place defibrillators. And we place those if we have a high suspicion that the patient could be at risk of having a life-threatening arrhythmia or abnormal heartbeat. And the indications for that are serious arrhythmias, in other words, life-threatening arrhythmias that we've documented, or a significantly reduced ejection fraction on echocardiogram. And then also if you have a PET scan similar to the one that we saw that showed that kind of extensive inflammation. We don't prophylactically insert defibrillators in patients with normal cardiac function, even if they have cardiac sarcoidosis. We treat the cardiac sarcoidosis with medications. Okay, shifting gears again a little bit about brain and nerve involvement, because this is another not common but problem that we see in the clinic. 5 to 15% of patients generally, and facial nerve palsy is the most common manifestation, although personally I haven't seen a lot of facial nerve palsy. I see the other manifestations more commonly. Basically, it's inflammation in the brain that's the problem. And this can be diagnosed by an MRI scan, and I'll show you an MRI here in a second. You can get peripheral nerve involvement as well. Large peripheral nerve involvement, which is basically weakness and numbness, and that can often be diagnosed with a nerve conduction study. But also in sarcoidosis, there's this emerging idea of small fiber neuropathy, and we know it happens. We just don't know how to treat it quite yet. It's diagnosed by biopsy, so basically it's a small punch biopsy where we look at the nerve endings and see that they have inflammatory changes in them. The problem is that we don't know how best to treat small fiber neuropathy or how common it is. And then there's some patients that get a myopathic form of sarcoidosis where it affects the muscle itself rather than the nerve. Again, that's a little bit more rare that patients become symptomatic. It's not rare that they find granulomas in muscles, but it's rare that people become symptomatic with that, or that they have elevated muscle enzymes such as creatine kinase. So we treat neurologically, as Dr. James mentioned, we treat neurologic sarcoidosis aggressively if it's in the brain. We use higher doses of prednisone, and we are quicker to add steroid-sparing agents. And we usually treat for a long period of time, relatively long period of time. This is an MRI of the brain that's abnormal. Again, similarly, you're looking at a cut through the brain. Patient's lying this way. That white there on both sides where the arrows are is abnormal. And this patient would have a severe involvement of neurosarcoidosis, severe neurologic abnormality. Okay, liver disease. Okay, so this is something that I see every day. When I see patients with sarcoidosis, I see liver disease every day. Luckily, most of the time it's asymptomatic, and patients don't have symptoms related to their liver disease. But often what you can see is increased liver function testing, and I'm going to show you a typical pattern from one of the patients that I see. And then you can get enlargement of the liver, that's where the hepatomegaly is, and other CT scan abnormalities. You can get nonspecific symptoms such as abdominal pain, fevers, and weight loss, but most of the time liver sarcoidosis is asymptomatic. And it rarely presents with advanced liver disease. So cirrhosis, portal hypertension, variceal bleeding, those are the things that we see in advanced liver disease in patients who have had very bad hepatitis, bad cirrhosis from drinking alcohol, and they end up with end-stage liver disease. It's very unusual to see that in sarcoidosis. So these are liver function tests from one of my patients, and this is what you normally see, or not normally, but what you often see in patients with liver involvement in sarcoidosis, mild elevations in their liver function testing. So actually, this patient's bilirubin is normal, and oftentimes you see that. The synthetic function of the liver, in other words, its ability to process bilirubin and move it through the gut, is normal. But they get slight elevations in what we call the transaminases, or the liver enzymes. And those are mildly elevated there. And then the alkaline phosphatase can be elevated as well. It's another measure of liver function, and also sometimes bone function or calcium metabolism problems. So do we treat it if it's mostly asymptomatic? Usually not. If they have abnormalities on their liver function tests, oftentimes I'll get imaging of the liver just to make sure that there's no other issue that we're missing. But oftentimes it's normal or just mildly abnormal. And like I said, these patients rarely develop synthetic liver function problems like bleeding and other things we see in cirrhotic patients. Okay, I'm not a dermatologist and I don't play one on TV, and this is one of the hardest things for me with sarcoidosis because people come in with all kinds of rashes, and it's really hard for me sometimes to tell whether it's sarcoid involvement or not. The good thing about skin involvement, it's usually cosmetic. It's usually not a life-threatening problem. So most of the time we have some time and we can do some different things to try to treat the skin disease, and it doesn't have to be immediate and subject them necessarily to the side effects of prednisone. Hopefully, corticosteroid cream will do the job. We also use Plaquenil, hydroxychloroquine, quite commonly for this disorder. There are some non-granulomatous lesions that can be seen in the skin with sarcoidosis, and most often they're seen with the acute presentation of sarcoidosis, where people get what we call erythema nodosum, or a rash on their anterior tibial surfaces that goes along with what we call Loeffler syndrome, or acute sarcoidosis, which the majority of the time resolves spontaneously. And this is just from the internet, a common skin lesion with sarcoidosis due to granulomatous involvement. So we're back. I'm almost done. Hope I can put you to sleep. We're back at our slide where any organ can be involved in sarcoidosis. I've seen some very uncommon things. I saw one woman who had bone marrow involvement, and that was her only, and this was proven with bone marrow biopsy, and that was the only manifestation of her sarcoidosis that I could find. She had no skin lesions, she had normal lung function, normal liver function, normal cardiac function, but she had pancytopenia, or reduced blood cell counts, secondary to her bone marrow involvement. I saw a gentleman who had isolated palatal sarcoid, so just affecting his palate, and it actually destroyed his palate, the inflammation, and he had no evidence of other systemic disease. So this disease it's exciting to take care of you patients that have this disease, but it's frustrating at times, and we as doctors, I think it's fair to say, like patterns, right? We like things to fit in boxes. We like to know how to treat things. We like to have algorithms that we put up here on the screen. Sarcoidosis is not one of those diseases. And the reasons that we have conferences like this and research that Dr. Drake mentioned is to try, not that we're ever going to be able to put people in the right box, but move those algorithms so we know what treatments work best and what manifestation of sarcoidosis. To have tools such as genetic tools or laboratory testing that can help us to determine which one of the medications that Dr. James mentioned is the best in that presentation of sarcoidosis. We really don't have that right now. And that's why the research is so important. And that's why I really appreciate everybody coming and spending their time to learn more about the disease. So just to very quickly, and then I'll be done, I promise. Other considerations in sarcoidosis, fatigue is a very common symptom, and that's one of the most difficult symptoms for me to treat. So patients come in with fatigue. I believe that they're fatigued. I believe that they have systemic sarcoidosis. They may have organ dysfunction. I put them on appropriate therapy. Their organ dysfunction improves, but their fatigue does not. I see that quite commonly, and it's a very frustrating thing. Depression is very common in sleep apnea patients. That number 2/3 is really high. That was self-reported. That wasn't diagnosed by a psychiatrist. But depressive symptoms are very common in sarcoidosis. And then sleep apnea, I think, is something that every sarcoidosis patient should be aware of, because sleep apnea is very common in sarcoidosis, and it can be life-threatening. So weight gain from steroids is quite common, and that can lead to worsening of symptoms. That's it. I appreciate your time, and I'd be glad to answer any questions.
Again, I'm gonna start in the front.
I just had a question. I've never had any of the other tests, but I've had a gallium scan some years ago. Could you?
Yes, ma'am. Gallium scans were quite common a number of years ago to diagnose sarcoidosis. And it's similar to the PET scan in that it's a measure of inflammation. So it's another attempt for us to see where the inflammatory problem is in the body. Most of us that do sarcoidosis every day have moved away from gallium scans. And if we were to consider that type of testing, we'd order a PET scan.
Okay, next question.
For people who have brain or neurosarcoidosis, and particularly have the lesions in the brain, how often does that lead to hydrocephalus, restriction of the spinal fluid?
Hydrocephalus is uncommon. Typically, you don't get, what's the word I'm looking for? The inflammation in the brain, it's not like you get when you have a stroke, where you get space problems, where you get inflammation that makes the brain grow in size and that pushes the brain in other areas. It's usually not that kind of inflammation. It usually doesn't make the brain increase in size. So not that that's impossible, but we don't see that commonly.
Okay, next question.
I am not understanding the mechanism that when they enter an organ, what starts happening? Does it create an inflammation in there, and so it starts fighting it back? I mean, it seems to me if it just goes in there, it just goes in there.
You mean
the granulomas?
The granulomas. Okay,
Yeah.
so the granulomas are a reaction, we think a reaction to an antigen. Okay, so they're an inflammatory reaction. So the body's exposed, we think, we don't know what that antigen is, but the body's exposed to some sort of insult. Okay, whether it's something common, like Dr. Drake mentioned, that we're exposed to every day and you have the wrong genetics, or it's something unusual that we're not exposed to every day, but the body has an incorrect inflammatory response to something that it's been exposed to. So that inflammation, it's like an autoimmune disease. The inflammation gets out of control and the body can't shut it down.
Okay, next question. We're going to take one more, and then the rest will be left for the Q&A session. For patients that have sarcoidosis in the stomach, difficulty digesting, what treatment options would you recommend for that, as medications are not digested properly to have a full effect?
Yeah, that's a very difficult problem. I fortunately have only had a couple of patients that have had that problem. A lot of times patients with a GI involvement won't tolerate oral medications very well. So what we like to do in those scenarios is use the TNF inhibitors. But the problem with that is getting them paid for by insurance. So oftentimes it becomes sort of a catch-22, because some of these infusion medications that Dr. James mentioned cost upwards of $100,000 a year. So you have to get insurance approval. And oftentimes insurances won't approve the medication until you've shown that you've failed oral therapy. So sometimes what we have to do is go through that oral therapy, show that it's not tolerated and not effective, and then we can get the infused therapy approved.
And so there have been patients who have used subcutaneous or intramuscular methotrexate. The only problem with that is that, it can take months to be effective, so depending on the severity of your symptoms. but that would be an alternative other than the IV infusions of infliximab and things like that.
Okay, that's gonna be our last question before break.
Yes, I wanted to ask a question on where he was talking about the heart, and by having not regulating good,
The arrhythmias?
the arrhythmias. Yes, do they put monitors to insert in your chest to monitor that sometimes?
No, how it's monitored in patients that have significant disease, those 3 indications that I put up there, we put in those defibrillators. And the defibrillator monitors the heart continuously, and then if it goes into an abnormal rhythm, it shocks the heart. And the idea of the shock of the heart is to get it back into a normal rhythm. It's an electrical charge that's administered to the heart. Non-invasively, in patients that we have a high suspicion of having cardiac sarcoidosis, we can send home with non-invasive monitoring. So it can either be for 24 hours or it can be for 30 days where you wear a monitor and that gets sent in and we can see what arrhythmia is, if there's any evidence of arrhythmias.
Okay. Wonderful presentations. Thank you, physicians. I've learned a lot. So we're going to take a break now until 1 o'clock. There are drinks and sandwiches and salads in the back. If you leave, the building is on lockdown because it's a weekend. So there are signs. We'll do our best to get everyone back in the building, but there are signs with the telephone number. Nadia, raise your hand in the back. We'll be letting you back in. So just please be kind to others. The building is just, we won't be able to let you back in if you give us a call. So reconvene at 1 o'clock. All right, thank you.
Listen.
Okay. I was hoping you could sit down. You were talking about the cardiac different ways, different ways. So that that's like 15 minute normal. So that's the order. Yes, sir. So if you've got an normal and you didn't have any symptoms or problems, that's fine. This point matter.